Good afternoon, and welcome to the PHSSR Research in Progress series, Bridging Health and Healthcare. I'm Angie Carmen. I'll be your moderator today for our topic, Applying Failure Modes and Effects Analysis to Public Health, Breathe Easy at Home program. We have two presenters today. The first is Dr. Megan Sandel. She's an Associate Professor of Pediatrics at the Boston University Schools of Medicine and Public Health, the Medical Director of the National Center for Medical Legal Partnership, and a co-principal investigator with Children's Health Watch, and a co-PI on the Boston Breathe Easy at Home study. Formerly, she was a pediatric medical director of Boston Healthcare for the Homeless program and is a nationally recognized expert on housing and child health. Presenting with Dr. Sandel today, we have Margaret Reid, who's a Boston Public Health Commission Director of Healthy Homes and Community Supports, which includes asthma, tobacco, injury prevention, and oral health programs. Ms. Reid oversees program policy and regulatory efforts to reduce exposure to tobacco and increase availability of smoke-free environments. So I'll turn the presentation over to Dr. Sandel now. We have two individuals that will provide commentary at the end of their presentation, and I'll introduce them at that time. I do want to invite all of our participants to put any questions that you have in the chat box. And so, Dr. Sandel, we'll turn it over to you.
Great. Thank you so much for having us today. We're really excited to present the Breathe Easy at Home program and specifically talk about one aspect of our study, which was applying failure modes and effect analysis to public health, the Breathe Easy at Home program.
Hi, this is Margaret Reid, and I'm going to start off with just giving a little background and context on the program, and then Dr. Sandel oversaw our FMEA, so she will really dive into the process, the adaptation of the FMEA, and some of the outcomes and directions that's leading us. So, Boston Breathe Easy at Home is a web-based program that allows clinicians to make online referrals for housing inspections, and these are inspections are by code enforcement inspectors who enforce the state sanitary code for housing out of Boston's Inspectional Services Department. And they make these referrals, clinicians make these referrals for their Boston patients with asthma. There are a number of asthma triggers that are covered by housing codes, mold, for instance, lack of heat, cockroaches and rodents, among some. So the inspectors are able to address asthma triggers using their existing authority. Clinicians receive an email notifying them of updates where in the process, and you'll hear more about the strengths and weaknesses of that as we go through the FMEA. And then we really feel that it encourages clinicians to ask questions to their patients about their housing because they have because they then can make a referral for resources. Just to give some background on the context, Boston is by U.S. standards an old city, and with that comes very old housing stock. In fact, our public housing is among the oldest public housing in the nation. We have a very high proportion of multi-unit housing and of rental housing. And then we are a majority city of people of color and have very significant racial disparities in many health outcomes, including asthma. Black residents in Boston, among all ages, have significantly worse outcomes than all other groups, and Latinos also have worse outcomes for asthma. I do want to say we have been having statistically significant improvements in asthma outcomes over the past number of years, so we're for Black residents, and we're very pleased with that. Boston neighborhoods are also racially segregated, so we really target our efforts and our services to those neighborhoods and those populations that are most affected, those neighborhoods with the highest populations of Black and Latino residents and also of multi-unit rental housing. Breathe Easy at Home is one program of a long-standing multi-sectorial partnership. And this is just kind of a visualization of some of the institutional relationships that we've been able to do housing work through for over 10 years. And, you know, as the Director of Healthy Homes and Community Supports at the Boston Public Health Commission, I often remind people I have no authority over any housing in the city of Boston. So if we didn't work with other agencies and organizations, we really wouldn't be able to impact the quality of the housing. Boston Housing Authority, I'll show you some of the other initiatives other than Breathe Easy at Home. They house 10% of the Boston population either through their own developments or administering Section 8. So, and it's often the least healthy group. So we all have really different functional capacities, and at the Commission, what we really bring to the table is data. I'll show some of the data, our ability to raise funds, to guide research projects with Boston Medical Center, which is our safety net hospital for the city of Boston, and to do public awareness and project management and coalition efforts. So this is just a sampling of some of the other, sort of a timeline and a sampling of some of the other efforts and achievements that we've done through our multi-sectoral collaboration starting in about 2000 when Boston Medical Center and Boston Public Health Commission applied for the first large HUD Healthy Housing grant, and it really helped to establish this office. And as you can see, Breathe Easy at Home was piloted in 2005 and really launched in 2006. We've worked with BHA on safe and effective pest control and on making themselves the first large housing authority to become smoke-free in the U.S. And worked about 3 years ago with our Boston Inspectional Services Department to create a proactive rental inspection and registration ordinance. So for the first time, well, they actually know what every rental property that exists in the city of Boston and where it is, and they are now able to proactively inspect rather than having just complaint-driven inspections, which we consider it was a very political achievement because it was very challenging, and having all these partners and community partners engaged around the issue of healthy housing was critical, but it's a huge public health achievement to not be waiting until someone's sick to look at the state of the housing. One of the reasons that we've been able to work with housers over the years is because we actually have health data of residents stratified by different types of housing. In 2001, Boston added a question about housing to the Boston Behavioral Risk Factor Surveillance System. So we're actually able to stratify our housing data. And people from our Boston Housing Authority have actually said to us if there's one thing that they would tell other communities to do, it's to ask that question, because it helps us to understand, to target resources, and to evaluate impact over time. So before I turn it over to Dr. Sandel, I'm just going to do a couple other slides. This is the Breathe Easy at Home process if it worked. And this is really what we, one of the foundations of how we structured our FMEA. This is what is supposed to happen every step of the way. And as Dr. Sandel goes through the FMEA, this is the steps where problems can happen that we really looked at, what could happen, what could occur, and how could we prevent or remediate that occurrence. And finally, you can see that Breathe Easy at Home referrals have steadily grown over time. We have every health institution in the city of Boston registered, and there are a lot. We're famous for our hospitals, and we are the home of the health center movement. But as you can see, while they've steadily grown, there is a huge amount of opportunity. And that is another area that we really have looked at in our FMEA is, you know, what do we need to do to really expand growth exponentially? And this, I should say, this is referrals. Another thing you'll hear about is because someone is referred, there are many opportunities in the system for the inspection not to occur or for the reinspection. So the FMEA really, that was a huge focus as well, is to close those gaps. So now I'm going to turn it over to Dr. Sandel.
Thanks, Margaret. I first want to just thank the Robert Wood Johnson Foundation and the Public Health Services Research Center out of the University of Kentucky, because we were lucky enough to receive one of those grants in order to evaluate our Breathe Easy at Home program. We really adopted a two-part hypothesis. We wanted to be able to understand that a multi-sector partnership enabling clinical providers to refer pediatric patients for housing inspections, whether that would actually be something that would reduce asthma triggers and improve symptomatology and quality of life. But we also wanted to evaluate the effectiveness of the partnership and to really improve our understanding of the barriers to its operation and establishing metrics for program effectiveness and quality improvement in the future. I'm going to focus the failure mode effective analysis, or what I'm going to call the FMEA, moving forward, was really an important part of our being able to attack this second part hypothesis. And then I'll also be able to talk about some mixed methods that we've been done, including electronic health record case review, qualitative interviews, quantitative interviews, focus groups, and then, of course, we're going to talk in depth about the failure mode effect analysis. So for those that are unfamiliar with what a failure modes and effect analysis is that it's really a process, a system science approach to identifying potential failures at each step of a complex system and developing preventative action plans to reduce the risk of damage. It is something that has been widely adopted in different industries, like, for instance, the automobile industry. One can imagine there are many steps in building a car where there may be potential failures. Or it's been adopted in the healthcare industry, where you could imagine dispensing the right medication to the right patient and avoiding an allergic reaction would be a complex system of many different steps. But what's interesting is that it's most useful when you can use it as a way to determine modifications moving forward and to really help to prevent problems and to prioritize what fixes need to be done first. And so when we think about the failure mode, the first thing is we talk about what could go wrong. We think about the causes of that failure mode and then the effects that it would have. What are the consequences of each failure, and being able to talk about it. We, in order to develop the Breathe Easy at Home FMEA, we said, okay, this is a standard protocol that usually is used by industry and healthcare. And so the Institute of Healthcare Improvement actually has a toolkit online. The Joint Health Commission accrediting hospital organizations, we sometimes call it JCAHO, JCAHO, and then the U.S. Veterans Administration all have toolkits related to how to use FMEA in the healthcare setting. What was interesting for us is we were adopting it now to a public health system, and so we were able to work with experienced professionals at Boston Medical Center, the Executive Director of Quality and Patient Safety, and the Medical Director for Quality Improvement to help us adapt the FMEA methodology to this public health system. And so in conducting FMEA, you have to first be able to select the evaluation process. So you have to really talk about from what starting point to what end point are you going to create it, and then really putting together a team of different disciplines so that you would be able to have different people from different points of view during the complex system to provide input. And so it's really important that you not only recruit that team, but that team remain the same throughout the process. This isn't a one and done, you have one meeting and you're done. It tends to be multiple meetings, and so it's really important to have continuity. And it's really important that in some ways that you have people that represent different steps of the process. It is unusual to have any individual that understands the entire process, and so it's really important to have different points of view for the discussions and their roles. You convene the members and you list the different processes, and so I'll be able to run through the specifics, but as you identify each potential failure mode, what the cause is and what the potential effects, and we'll talk about how you rate the effects around severity and occurrence and detectability, that you can create what's called a swim lane chart. So those are different people that are involved at different steps of the processes and what each potential failure mode is, and then you list the failure modes and their causes. So in listing the failure modes, the causes, and the effects, you end up assigning a risk priority number. And that risk priority number is basically around, you take 3 different numbers and you multiply them. So you take the likelihood that it occurs. So we adopted a scale that was related to very likely to occur down to very unlikely to occur. We talked about the severity, so whether or not it was a less likely to be severe up to maybe someone gets hospitalized because of the failure of the severity. And then the ability to detect it, because this is a multi-sector system, oftentimes different people at different sectors will not be aware of it. And so the idea that you would know how to detect the failure mode was really important. And then you would assign that risk priority number as a way to then be able to prioritize what changes you need to do in order to reduce the risk of the failure mode. You then be able to evaluate your results and then make plans for improvement. And the ultimate goal of an FMEA is to set up the quality metrics and the kind of plan, do, study, act cycles that you can do in order to improve a failure mode. So what we did is basically adapt the FMEA evaluation template to a small public health program like Breathe Easy at Home. And we built our Breathe Easy at Home FMEA team consisting of individuals with extensive understanding of the process and representing different roles. So we had an ISD inspector who conducted Breathe Easy at Home inspections. We had a physician who referred to the Breathe Easy at Home program. We had the parent of an asthmatic child who had received Breathe Easy at Home inspections. We had a community health worker representing a different member of the healthcare team who conducted asthma home visits and also referred to the program. We had an administrator at ISD that handled the referrals as they came in and assigned them to inspectors. And then we had a housing authority representative responsible for maintenance when they received these Breathe Easy at Home complaints. This is a busy slide. It's not meant to necessarily be read, but it's meant to give you a taste for what a Breathe Easy at Home swim lane chart looks like. And here you see different practitioners or different roles that are listed on the horizontal, and then you have different times of where a failure mode could occur. So a healthcare provider in many ways needs to be able to ask a patient about housing quality in order to then refer them to the program. They need to understand how to refer. They need to be able to be part of the network to be referred, and then actually get the patient to tell them about the housing conditions, et cetera. And so as you can see, the referrers are represented on the left-hand side as having actions, but then the guardian of the child or the asthmatic is then involved. The Breathe Easy coordinator, the ISD administrator, and the ISD inspection happen at different time points in the complex system. So as I said, the way that we would do it is first you would identify all of those different failure modes and you would put them into a swim lane chart. And then each of the failure modes would then be prioritized and ranked based on this 3-part score, this risk prioritization number that was generated by multiplying the severity score by the occurrence score by the detectability score. And so what we did is we adapted more from the U.S. Veterans and Administration, which had a 4-point scale. So the severity would be that there was a minor event, such as a delay in an inspection, would be a 1. A moderate event would be that there was dissatisfaction with the inspection and families were unhappy with it. A serious event could be that a landlord started to be angry with a tenant and retaliate would be a serious event. That would get a score of a 3. And a catastrophic, in this case with the USVA, they talk about it as death. We said catastrophic was that the severity would be a hospitalization for a child with asthma. Again, occurrence had a 4-point scale of a 1 being a remote occurrence once or twice during the program's history, an uncommon occurrence maybe once every 1 to 2 years we get a 2, occasionally would happen 10 to 20 times in a year would be a 3, and a frequent 50 more times in a year would be a 4. And then we adapted a detectability scale from the Joint Health Commission in order to say that it was almost impossible to detect would be a 4. We would be a slight ability to detect after the failure, but you become aware of it and you can investigate a 3. A medium size would be you'd have to proactively look for it, but you could find it. And then the high would be the failure would be most immediately revealing. And so once you have the risk prioritization scores of each of the failure modes, then the FMEA team will then qualitatively group the actions together so that you could prioritize types of activities that seemed like each other. And so in this, we were able, the FMEA team, to generate 4 categories that we thought were important. And so we first said that it was important to improve healthcare staff education. And as you can see, the severity, occurrence, and detectability is represented as contributing to the highest risk prioritization number groupings. Then it was improving parent education was the second priority action. Then we had changing the contact protocol for scheduling inspections. And the last was changes to the website that would assist with referring. To break it down a little bit further, you can see in the table of each of the different failures that we felt like needed to be addressed. So for instance, you would see the top tier would be improving staff education. We had the staff must know about housing conditions. They must screen effectively. And as you can see, the severity of that was quite high. It occurred very frequently and was difficult to detect. And therefore, it created one of the highest numbers for the severity times occurrence times detectability. And then as you grouped all the things that were related to staff education, that had the highest total RPN number and therefore was the highest priority set of actions for us to occur. So just to give you a sense, this is not just an activity to generate where the failure modes are, but it's also to generate actions to improve the quality of the program. And so for us, the actions proposed to address the failure modes, our first priority was improving clinician education about the program. So we've created new training videos for healthcare professionals. These are very short YouTube videos in the 2 to 3 minute range that someone can easily watch so that they can understand the program better. We provided updated, simplified, and translated outreach materials for healthcare facilities so that families can get, that healthcare providers can better explain the program to their families. We're starting a regular outreach system where we will do kind of just like you would detail an office around a new drug, we're going to detail offices about the Breathe Easy at Home program. And we're really encouraging, particularly in the electronic health record age, to do universal screening and to be able to integrate that into the clinic flow. The second area that we talked about was improving guardian or tenant knowledge about the program. We also created YouTube videos for parents as well as landlords to be able to understand the program and what its goals are. We're really looking at utilizing social media to address concerns and being able to get the word out through both podcasts, Twitter feeds, and other things. And we're also conducting outreach to community organizations so that there can be more knowledge within the community about the program. So when a provider introduces the concept, it's not a new idea. The third area would be adjusting the scheduling protocol. We realized that many of the referrals did not actually result in an inspection because of ways and really archaic ways to reach families. These days, calling families may not be the best way to reach them, so we've been able to think about text messaging, automated voicemail, email capabilities. We're trying to eliminate using the U.S. Postal Service because many of the families reported not getting the letters scheduling inspections. And then we've also asked that families confirm scheduled inspections so that there would be the ability to make sure that inspectors don't go out and the family's not home. And then lastly, we realized that there was important changes to the Breathe Easy at Home website. We need to make it more user-friendly for the clinicians so that they could easily make referrals. And then we needed to increase the number of mandatory fields and checkboxes where someone could include multiple phone numbers, say that it's okay to text and email, and be able to approach families with the idea that they could request a first morning inspection or an end of the day inspection for working families. I think that for us, the FMEA had great implications for public health practice and policy. We're really excited to successfully adapt this methodology used in larger scale hospital and industries to a smaller scale public health program. And I think it really, from my perspective, opened up ideas that I wouldn't have normally thought of. I knew that we probably would have issues in quality around scheduling, but it would have never occurred to me that staff education was the most important failure that we were missing. And so it really helped us to do a quantitative approach to the problem. I think it helped to identify potential failures and then to help us develop evidence-based corrective action plans. And it helped us prioritize risks that had different occurrences that may occur in the healthcare setting. And so for us, it was really important to be able to not only address dissatisfaction, but things that could be risk with asthma morbidity and mortality. Just to give you a little bit of a flavor, this is only one aspect of our research grant. So we had done qualitative focus group style interviews with 10 referring clinicians where we did one-on-one phone interviews. These were different healthcare professionals, so 3 medical doctors, 3 nurse practitioners, 2 registered nurses, 2 community health workers at multiple separate Boston-based health institutions. We also conducted one-on-one phone interviews with Breathe Easy at Home clients in order to get a sense of what their views of the program were. We were able to do a focus group with 9 inspectors in the Inspectional Services Department who have worked on Breathe Easy at Home cases. We were able to do a focus group among the stakeholders that come to Breathe Easy at Home meetings, and these include a pediatric nurse practitioner, a community health worker, attorneys, the Inspectional Services Housing Director, health and housing advocates, parents of children with asthma, and representatives from the Boston Public Health Commission. And lastly, we've been doing a chart review of Breathe Easy at Home clients that were referred. We are able to do that from the medical records of people that were referred from Boston Medical Center in order to monitor changes in healthcare utilization and environmental improvements. Yeah. So Margaret's going to talk a little bit about some of the focus group and interview findings that we found and how many of them reinforce what we learned in the failure mode effect analysis.
Yes, we were maybe surprised to see that many of the focus group and interview findings really reaffirmed. So for the purposes of this, it made sense really to cluster this feedback, to organize it the same way the failure modes were prioritized. So about parent education, just educating the parents don't really understand the program, and there are concerns and risks about the program, which may be valid. The inspectors felt it was really important to build trust with tenants, and that they also need to build trust with the landlords, because the landlords need to understand that this is a health initiative. It's not an attack on their property. And I think that's an area where thinking about proactive and universal screening will be really helpful. The clinicians found the website time-consuming and inefficient, and not providing enough feedback that they want. the inspectors found that they weren't getting accurate information, really. So that gets back to provider education. And then the contact protocol. A clinician said really between the referral and the inspection is where we have lost a follow-up. And our scheduling has been, we're really looking at scheduling. One thing Dr. Sandel didn't mention is we're looking at early in the day or end of the day scheduling to recognize that people work. Despite all the feedback and the FMEA, there's universal positive attitudes about the partnership and the program. The inspectors really felt that it was helping them to improve housing conditions and asthma symptoms, as did the clinicians. Here's just a quote from an inspector, but they actually, occasionally they do receive calls from tenants who are the clients, the parents of asthmatics, and from clinicians saying, by the way, thank you, this worked. Where we're going is, do you want to talk about this?
So I think, as I mentioned before, we do have additional analyses. We have our mixed methods are including quantitative interviews with 3 different groups for our understanding of the program. We are looking at people who were referred but actually did not receive or participate in getting an inspection. We're looking at people who were referred and actually received services. And then we actually are looking also at people who were referred, received a code enforcement inspection service, but also received an asthma home visit service. So the idea would be is trying to see if there was kind of a dose response to it. After patients participate in, or I should say the caregiver of patients participate in the quantitative interview, they're also invited to then participate in a semi-structured qualitative interview. I'm sorry, I put a typo in there. It's qualitative interview. And then we also consented them during this process for the chart review for healthcare utilization, and we're doing that through an electronic health record data pool out of our Boston Medical Center system that includes some of the community health centers in Boston. So some of the products that we've been able to produce so far, we have completed some updates to our website. And for those that are interested in learning more about the program in general, we did publish a really nice article that walks through all the steps of the program in the Journal of Environmental Health that was published in January, February edition in 2014, and is included in some of the resources on the top right-hand corner. We're in development of actually a manuscript that was being submitted to Frontiers and hopefully will be in its next edition. We just revised it and resubmitted. We also have a multi-sector qualitative research grant describing the results of the stakeholder interviews, the inspector focus group, and the clinician interviews. And then we also have training and promotional videos for patients, community, and referring clinicians that I mentioned. And then ultimately we're going to do a manuscript around the mixed methods, including the health outcomes. I just want to end by, again, acknowledging the Robert Wood Johnson Foundation funding and specifically the Public Health Services and Systems Research Program at the University of Kentucky College of Public Health. We really couldn't do the Breathe Easy at Home program without the Boston Inspectional Services Department. They've been an enormous champion, and really I applaud them because in the culture of health, they include health now in their mission. And so when a code enforcement agency talks about health being part of their mission, I think that that's a really great example. The Boston University School of Public Health has been a great partner, particularly in the qualitative interviews and analysis. The Boston Housing Authority is a huge proponent of the program, and we continue to have annual healthy housing meetings where they bring all the maintenance and managerial staff from Boston Housing Authority to meet with the Inspectional Services Department inspectors and Boston Public Health Commission staff, and they really have prioritized that. And our parent asthma leaders at Health Resource in Action has given us great feedback about how to make a better program. Thanks.
Thank you very much to both of our presenters. That was a great presentation and very well laid out. I would encourage all the participants to put any questions that you may have for either of the presenters into the chat box, and we'll get to those right after we hear from our 2 commentators. The first is Dr. Jonathan Levy, a professor and associate chair of environmental health at the Boston University School of Public Health. Dr. Levy's research centers on air pollution, exposure assessment, and health risk assessment with a focus on urban environments and issues of heterogeneity and equity. So Dr. Levy, we'll turn it over to you.
All right, thank you so much, and thanks for a very interesting presentation. I enjoyed learning about the work that was done. I think very broadly, as mentioned, my background includes risk assessment and other related fields such as decision analysis and system science methods, and this application of failure mode effect analysis, or FMEA, sort of lives within that universe of applications. And so I found it to be a very creative way to take methods that are usually used in other fields and disciplines and develop some novel insights. To help to ground myself, I'm not an expert in FMEA, to help ground myself in the field, I did a brief literature search, and interestingly, as I think Megan alluded to, a lot of the earliest applications of this were through things like the military or NASA, and in fact, the focus on the more qualitative or semi-quantitative aspects of FMEA actually came after NASA did a quantitative risk analysis of the probability that the moon landing would be successful, and they didn't like how the numbers came out, and so they decided instead to focus on these types of analyses to help to identify problem areas and reduce the possibility of harm. It was also, I think, very famously used by the automotive industry, including after the Ford Pinto calamity in the 70s, Ford and then others started to adopt the method. So it's been very much in the world of engineering, operations, research, and computer science, but increasingly we've seen the tool used in the realm of healthcare. And in the quick literature search I did, there were a number of studies, not a huge number, but a decent number in the healthcare arena, and more than half of them were published in the last 5 years. So obviously increasing recognition that these techniques can be helpful in the area of healthcare delivery, where you obviously have a lot of steps in the process, a lot of places where things can go wrong, and with the focus on medical errors and general healthcare system efficiency, it's understandable how these techniques have been brought in. But there's been very little in public health, which I think Megan alluded to and makes this quite exciting. The things I found in the public health arena tended to focus on things like worker safety and other occupational risks, where again there's a very specific and delineated set of tasks, and it's perhaps easier to identify where faults can occur. So briefly, I kind of wanted to highlight 3 things that jumped out at me from the presentation that seemed novel, interesting, important to focus on. And I think some of these were mentioned by the 2 presenters, but I wanted to reinforce the points. I think one very important aspect was the interdisciplinary team that was quite diverse from different occupations, different perspectives, and so forth. And I think to do FMEA correctly, you need a group like that. And I think where these tools tend not to work is where you miss an important failure mode. Again, going back in history, I think one of the more famous sort of fault tree analyses or more complex versions of this was in the 1970s, the nuclear reactor safety study tried to quantify the probability of a catastrophic nuclear meltdown, and it really missed the boat, did not predict the kinds of things that happened at 3 Mile Island, for example, because it really focused on the engineering aspects, and there was a lot of groupthink, and there was sort of very little thought about human error or so-called common mode failures, where a very similar problem could sort of ripple across the system. And so having people approaching this from different perspectives who could think outside the box seemed crucial, and it seemed to be reflected in the outcomes where you had a variety of different failure modes that are identified across different spheres. I think one of the other challenges that you see with these kinds of applications, which really do span kind of sort of semi-quantitative and semi-qualitative, one of the challenges is how robust are the numbers that are developed and how interpretable are they. You're multiplying 3 things together for the sort of risk scoring, but those things may not be equally important to one another, and it may not be that if you have a 1 in one category and a 2 in the other versus a 2 in a category and a 1 in the other, that they should be treated equivalently. But it seemed that the researchers put a lot of thought certainly into the categories, into the ranking scales. It looked like they did not just take existing scales verbatim, but really thought very carefully about how you could adapt those scales to this context. So I think it's still always something to keep an eye on of how these scoring systems work and what happens with the mathematics of things. But I think it was important that the group was very thoughtful about how the points were assigned and therefore how they were combined. And I think this was mentioned a couple times in the talk, having not just these types of FMEA analyses, but focus groups alongside that is quite crucial. I think you can get hopefully some comparable insights, but perhaps some differences as well. And so I think blending the qualitative with the more quantitative or semi-quantitative insights from FMEA, I think gives you a much richer set of characterizations and better identification of how you could improve systems. So to wrap up, I think there are a lot of opportunities to apply these types of techniques to public health problems or in general to use system science tools. Our group in collaboration actually with Megan and colleagues have used system science techniques called discrete event simulation in some recent studies. Again, taking a technique that has more often been used for large-scale health policy analyses or queuing problems and adapting them to a specific circumstance, in that case, targeted residential interventions related to ventilation and other aspects of the indoor environment, thinking of how they improve pediatric asthma. So I think, we in public health, environmental health, healthcare should really look towards some of these other established methods and disciplines in risk analysis, decision science, and system science to help us come up with high priority public health measures and especially to try to improve programs and improve systems wherever possible. Thank you.
Thank you, Dr. Levy. We'll move on to our second commentator now. We have Dr. Osagie Ebekozen. He is the Director of Accreditation and Quality Improvement at the Office of Racial Equity and Health Improvement at the Boston Public Health Commission. In this role, he works with a team of dedicated professionals on numerous large-scale improvement initiatives and coordinates the organizational local public health department accreditation. So Dr. Ebekozen.
Thank you. Thank you so much. And I also want to congratulate Dr. Sandel and Ms. Reid for their success and for the great presentation. It's been very helpful as a quality improvement professional to listen to them and actually see how they're applying these tools to public health. Some of the comments I had prepared had been stated by Dr. Levy, so thank you to Dr. Levy for sharing those insights. A few things that I still want to point out. Dr. Levy had talked about and Dr. Sandel too about applying this quality improvement tool in public health and why that is still new. I feel more local public health departments and state public health departments are now going towards using established quality improvement tools. In 2013, the Public Health Accreditation Board was established, FAAP, and they were charged with actually creating an accreditation framework that will incorporate quality improvements into delivery of essential public health services. Right now, we have about over 70 health departments, about 60 of them local health departments and 10 state health departments, and about 2 tribal health departments already that have been accredited. Boston Public Health Commission is in the process of doing that, and we're working with staff on what that will look like. And the beauty of pushing accreditation across board in local public health departments is the standards, the measures, a lot of the things that you would need for accreditation really would force us as public health practitioners to start looking outside of our regular zone. What's out there, what can we use? There's actually a domain, the domain 9 on the accreditation standards that talks about applying quality improvement tools in delivering essential public health services. So I'm happy to see all of this happening, and it's exciting. And my prediction is in the next couple of years you will see many more of public health departments and public health partnerships applying well-established quality improvement tools in delivery of essential services. One thing we say as public health professionals and improvement experts is every system is designed to get the results it gets. So whatever we're seeing in our program or whatever output or whatever outcomes we get, that's literally how the system is designed. A typical response, traditional response to problems in service delivery or in public health is, one, I don't have enough money. So where are the funds? We don't have funds for this. We don't have grant for that. Another response we typically get will be, oh, well, this person is not doing a good job or that person is not doing a good job. We always want to put blame on someone else. I want to blame the inspector. I want to blame the coordinator or blame the community health worker. But in systems thinking, we realize that about 85% of the problems are from the system and not individuals themselves. So having a structured way of actually looking at our system at every stage, both to prevent a problem and also to improve the process of the system itself, would help in getting better outcomes, and will help to design a better system or to prevent the already existing system from delivering results that are suboptimal. So using a tool like the failure mode and effect analysis, the FMEA, really has helped Dr. Megan and Ms. Reid and the team working here at Boston Public Health Commission and the BU School of Medicine, Public Health School, to use a structured tool to really look at the current system. So what exactly is our current system and why are we getting the results we get? And with this, being able to prioritize and not just blame individuals, so just decide that, well, this is not achieving the result we want because of this problem or that problem, but to look at the system or the process as a whole. And to be able to do this in a structured manner would help in two things. One, figuring out where's the best place for us to put the restricted fund or the restricted resources. Because there's always that pressure for funds. There's always the piece on, we don't have enough money, and that will always be there. But if we do have this amount of dollars or we do have this resource, where should we put this to get the best value or get outcome? And that's one thing that the group has demonstrated with the FMEA to identify what's the best place based on the risk score to actually put the funds. The other piece to this is, even without a very robust funding or without the funds or the grants, the FMEA on its own can actually help us identify low-hanging fruits. So are there opportunities that we don't need to have a new website, or we don't need to come up with a whole new set of training, but there are low-hanging fruits that might not be high up on the score, but there might be things that won't require so many resources to do, and we can pretty much early on attack those low-hanging fruits and prevent that problem from happening and actually improve the process itself. So that's another thing the FMEA itself can help with, and which I've seen the team do, because and in the presentation they had highlighted some of the other things they're working on that wouldn't require all the heavy investments, as opposed to the video and all of that might need additional resources. The final thing to state is FMEA in itself as a tool can even be further customized to address health equity. The way the program is designed and the way the program is set up and the process really was intended to target that. But one thing we understand in health equity research and disparities is the systems that created those inequities and the disparities are different from systems that just create low health outcomes on their own. So there's systems of oppression, from racism to all of the other systems of oppression that actually creates the inequities in themselves. So using a tool like FMEA in a structured way, customizing that tool to force us to think about what are the systems that created or that's created or inherently built in to create inequities in the first place, and how can we reverse that, would help practitioners, public health professionals to be able to tie all of those pieces together and think outside the box on, if our focus is on achieving equity, how can we think about this? How can we customize this work we do? And how can we present that in a structured way to actually be able to address this piece? So, I congratulate the team, and this is great, and I'm excited. It's exciting to see more of this happen, and I look forward to a more engaging discussion in the future about applying quality improvements in public health practice.
Thank you so much to both of our commentators. We will now open the chat box again for all the participants. If you have any particular questions regarding the presentation or any of the comments made by the commentators? Give people just a moment to do that. While we wait, I would like to ask any member of the team how you selected the failure modes and effects analysis framework or tool in order to improve this process. We know there are several with quality improvement, and this one is such a nice one, and as you said, is often used in other industries. And I just wondered how you came about selecting this tool.
Yeah, thank you so much for that question. I think that in many ways, we were attracted to failure mode effect analysis, I think in two ways. I think the first is that we really viewed Breathe Easy at Home as a system. And so we could have just focused on the individuals and their asthma outcomes, or we could have just focused on healthcare utilization, but we really wanted to be able to evaluate it as a system. And this one is one of the, I think, more well-described system science methodologies. I think the second is that I think we're really excited about being able to start thinking about accountable health communities, thinking not just on the individual or the institutional level, but on the community level. And as we think about pooling healthcare dollars and public health dollars together, we really wanted to use a system science research that we thought healthcare institutions would understand. And so that we really felt like being able to talk about the quality metrics and then be able to talk to healthcare institutions across the city to be able to not only discuss how we were talking about improving the program, but that also we were talking about what the return on investment of this system meant, I think was really important. Just to give you an example, so one of the co-authors on our FMEA paper is our vice president for quality at the hospital, and what she was saying was maybe we need to eliminate a screening step so that we don't just screen people who are hospitalized with asthma. We look at where they live and we look at different profiling, and we take that step out so that we eliminate that as a failure mode, so that we make that an automatic part of, you get admitted to the, to Boston Medical Center for pediatric asthma, you live in a certain district, we're going to automatically refer you to Breathe Easy at Home because we know that's important, and we'll explain it to you. And so I think that thinking more and more about integrating systems of healthcare, public health, and community will be really important.
Thank you. I appreciate that. We do have another question in the chat box. What advice would you give to other local health departments seeking to start new relationships with housing agencies and develop initiatives to address housing issues and related health outcomes?
I'm sorry, could you say that question one more time?
Sure. What advice would you give to other local health departments seeking to start new relationships with housing agencies and develop initiatives to address housing issues and related health outcomes?
Thank you. We get that question a lot, which really speaks, I think, to the absence of relationships between public health departments and housing agencies, which is sad because historically public health was all about social determinants of health, and we're, where you live, where you work, where you get your water from, and we're really starting to go back there. I think some of the, we really have been told by our housing authority being able to speak to them with data has been huge. So I think thinking about, is there data that is of interest and to start a dialogue is probably one thing to think about. The other thing that we have, I think it's also important to realize that these housing agencies, they have a mission, they have a mandate, so we have to be able to kind of apply our interests to their mission. And when we talk to like housers, and I'll use tobacco for an example, we often can talk about, well, how many relocation requests are you getting? Because relocation requests cost money and they cost time because people don't want to live next to a smoking neighbor. That's the language they speak. The other thing is, when we can help them to succeed, that is huge. Our ISD, their chief of staff won a national award for Breathe Easy at Home, and as part of her acceptance, she was talking about how they don't get recognized and they don't win awards. And so really, recognizing the effort that they are putting in, I think is huge.
I think the other take-home that I had, particularly around Breathe Easy at Home, was the idea that it's all about relationships. It's really building relationships with people in these agencies, and that can sometimes take time, but it's a really worthwhile investment, and that many of these agencies suffer from reputations, right? Boston Housing Authority or Boston Inspectional Services for years had reputations as being dysfunctional, and really cutting through that and just saying, I'm here to help you. I'm not here to embarrass you or to call you out on not doing your job. I'm here to make a difference. And really being able to build those relationships, I think, made a huge difference. And that strength then meant that when they needed help, they would call us. And when we wanted to write grants with them, they were at the table and wanted to work on it.
And the one other thing I would add is we can't underestimate the importance of community representatives and, community advocates going to the housers and helping to bring us together, public health and housers together. Officials listen, hopefully, to community residents and to community advocates, and they should. So that voice is really important. And another voice that we have found that's been invaluable in Boston is the clinical voice. Our city council, our housers, when a doctor talks about their patient and their patient's housing, people listen. So I think, so it's doable, and taking advantage of all these different, whatever leverages are available is a good place to start.
This is Ann Kelly. I think that Angie Carmen has lost audio contact, so I'll thank everyone for their participation today. I'm sorry that Angie lost the final contact, but we appreciate all your comments and participation. I have loaded a link into the chat box for everyone to please give us some feedback. We're doing a follow-up survey for the series of webinars. If you have any comments about this and the others. Do any of the other speakers have any parting comments?
No, just thank you very much. This has been a really wonderful opportunity to share this, and we're really looking forward to our next steps to improving this system.
Okay, thank you so much. We'll sign off for today.
Thank you.
Thank you.
Thanks. Bye-bye.